Good morning, everyone. We're gonna give our attendees about 5 more minutes to log on. We have a lot of people who have signed up for today's webinar, which is great, and people are jumping on here. So we're going to give it about 5 more minutes. So please sit tight, and we'll be underway here pretty soon. Good morning, everyone. Thank you for your patience as we allowed some time this morning to allow others to jump onto the call. We've had a lot of people register for this timely information, so we appreciate your patience. I'm going to get started now with a couple of housekeeping issues and wanted to welcome everyone. Thank you for joining us for today's webinar, UPMC Community Health Choices Nursing Facility Review. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. This webinar is being recorded and will be made available on the PHCA website by the end of the day today. Today's webinar is informational and not for credit. Feedback is important to us, so we'll be sending you a survey following the webinar. Please complete this survey, and if you are participating in a group setting, have each participant also complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Now for today's webinar. This webinar is being presented by Andrea Farrell, Director, Ancillary and Community Health Choices Network Management with UPMC. Also joining the webinar in a little while will be Edward Platt, Vice President of Operations with Coordinated Transportation Solutions. The focus of today's webinar is to provide information on UPMC's billing process and payment structure, service coordination in the nursing facility, transportation services for nursing facility residents, incident reporting, and provider disputes, complaints, and grievances. Time will be allowed for attendees to ask questions of the presenter on issues or situations they are experiencing in their respective facilities related to residents enrolled in the UPMC CHC. I'll now turn the webinar over to Andrea.
Thank you, Wendy. Good morning, everybody. As Wendy said, my name is Andrea Farrell, and I'm the Director of the Ancillary and Community Health Choices Network. I've worked with most of you in the skilled level, and now it's a natural progression that we're picking up the Community Health Choices Medicaid portion in your facilities. So the purpose of our presentation today is hoping that we were able to get in front of a lot of the staff members at the facilities who I know have a lot of questions, and hopefully the presentation will answer your questions. First, I'd like to do the introduction. I introduced myself. Also on the webinar is Danielle Walker, Rupert. She's recently married, so her new last name is Rupert. She is our network manager for nursing facilities, and her role is to function as a liaison with the nursing facilities as they are on your day-to-day issues and concerns that you have. So I have Danielle's phone number there, and I have her email that you can contact, and I'm also available if you need me. As discussed, today we're going to have an overview. We're going to talk about billing processes. We're going to talk about service coordination, critical incidents, complaints and grievances, and I did move transportation to the end of the presentation. So the first thing I'm going to talk about is eligibility verification. There are varying manners that you can obtain members' eligibility. First off, I want to say that your functioning that you do on the Medicare side for the skilled nursing or commercial the processes do not change. You're still working with UPMC Health Plan. Nothing has changed in our processes for you to function for your Medicaid population. So it's the same processes and nothing has changed. So we offer our UPMC Provider Online portal. On that portal, you have the ability to chat and you have the ability to see the members' eligibility page. If you do not have access to the provider portal, you can speak with Danielle and she can assist to get you the access that you need for that portal. The DHS EBS system is always the tell-all for Medicaid eligibility, so you should continue to use that portal also. I now have a dedicated UPMC Community Health Choices Provider Services team. That number is 1-844-860-9303. That number is different than the provider services number that you used previously. You can use the previous number, and then they will transfer you over to the UPMC Community Health Choices number. The provider manual is available on our website. I will tell you that we are in the process of getting it updated to outline some of the skilled nursing processes, et cetera, that we now have underway and have tested that are working. A few things that I want to talk about: the CHC member ID cards, if you are seeing them. The first card that you can see is a Medicaid-only member. So when we talk a little bit about the UPMC Community Health Choices member, there are two different types of members. One member is a straight Medicaid member. They do not have Medicare primary. Their physical health and their LTSS benefits fall under the Community Health Choices product. That member prior was a Health Choices member. That member prior was a potentially UPMC for You or Gateway or Aetna member. They, with the implementation of CHC, they were no longer able to stay within their Health Choices plan. They were required to move into one of the 3 Community Health Choices plans. What that means is they now have one product. They have either UPMC Community Health Choices, or they have AmeriHealth Caritas, or they have the Pennsylvania Health and Wellness Plan. The second card that the first card where it's Medicaid only, many of these members will also be dual eligible members. That means that they have Medicare primary and Medicare remains primary. That is very, very key to remember, that a Medicare member always remains primary, and their Medicare benefit is always primary, and Medicaid should be the payer of last resort. So if a member the member does not have to be fully integrated with both of our products. They can have whatever dual eligible plan they choose. So if they are a Gateway dual eligible member, they can choose to keep their Gateway dual eligible, and then they would have one of the 3 MCOs for Community Health Choices as their secondary and LTSS payer. So that is important because, again, we are looking to have these benefits coordinated the best that you can coordinate them. So you may be working with one Medicare company and a separate CHC company. So if you see that first card that only has a Medicaid ID, that's telling you that they are either a full Medicaid member or they only have UPMC Community Health Choices as their secondary payer. The second card shows you a member that is fully aligned. So that means that they have our dual eligible Medicare, UPMC for Life dual product, and they have chosen our UPMC Community Health Choices product. You'll see on the card, which I do apologize, it is a little blurry, but there will be a primary ID and a secondary ID. Primary ID is their UPMC for Life dual Medicare ID, and the secondary ID is their Medicaid ID. So when you're functioning, you will want to function under the correct ID based on the service that you're providing. A little bit about billing. DHS required the MCOs to continue following the current billing process that DHS had in place. So when claims are being submitted, they're being submitted the exact same way you submitted them through to DHS. The difference is you're not submitting them through the Promise portal. You now have to submit them directly to us. We've been working with all the facilities and appear to have all of the billing relatively calmed down. Some facilities are billing using their EDI clearinghouse provider. If you're having any issues using your clearinghouse, you can contact us and we can help work through those issues. The clearinghouses are they're just getting used to submitting it to the MCOs. So some of them do have some questions and things, and we can meet them up with our EDI so that we can make sure that we get that to be a smooth process. Providers also can bill paper claims. The paper claims would come to us directly and be processed as any other paper claim or claim that we've received. And we are in the process of having our provider portal on our secure website updated so that you can enter claims in the portal. I did receive an email today that it was going live. We're going to test it with a provider or 2, and then we'll get information out to everyone to tell you that you can begin using the portal to bill your codes. I jumped the gun here. So here's some information on our electronic claim submission and our provider online and the address for the paper claims that they can be sent to. At this point in time, it appears as though we have successfully billed with almost every nursing facility. We have a handful that we're still waiting for some claims to arrive, but we need to have a one-on-one with everybody and make sure that we understand any issues that anyone is having. I do ask that you work through your MCO contact. Most of the facilities have a direct MCO contact that is working with us one-on-one and working with Danielle to ensure all the claims are processing correctly. It is a new process on our end as well as it is on your end, so we're making every effort to make sure things are being processed correctly. Just a little more information. These are just the varying links to the DHS billing manual, etc. Those are what we used in our claims processing. I know that some of you on the phone may have ran into a little snag. We were requiring something on an electronic claim that we shouldn't have. We verified with DHS that it wasn't required, and we've adjusted all those claims. So I think we have the claims process to the point that we are processing correctly. I'm going to skim through this. This is basically just telling you that your claim should look the same as it did when you submitted it to DHS. The only difference is you're submitting it to us. We have all of the scenarios. They were given to us by DHS. Do I think that we potentially could run into a scenario that we didn't see? I will honestly say yes. And that's where I ask that we all work together to walk through it to make sure that we all have the right process understood. I look at this very much as a partnership between us. You know, you'll hear me stress this through the entire webinar, that we need to work together to ensure that you guys are telling us what is or isn't working, and that we are working to rectify it as quickly as possible if we need to. Very quickly going over the payment structure, all facilities are on a base per diem rate. That base per diem rate is on a contract that was signed with your administrative staff. UPMC Health Plan will be processing bed hold payments. DHS is providing us the list of facilities that fall within the 85% of occupancy, and it will be based on your prior quarter results. If you meet the above qualifications, and you should know who you are, UPMC will reimburse the facility a third of the then current per diem rate, with a maximum of 15 hospital reserve bed hold days per reimbursement per authorization. If you have any problems with bed hold days, please let us know immediately. The rate has been configured to be a third of the per diem rate, so they should be processing correctly, but if there are any issues, please let us know as soon as possible. Hospice payment days, per the DHS guidelines, UPMC CHC will reimburse the nursing facility for the per diem rate, and we will be reimbursing hospice providers for the hospice services separately and directly to the hospice provider. The one question I ask is, would you please let us know the hospice providers you are using so that we can ensure that they are participating with the community health choices so that we don't have any issues. If they're not participating, we'll work as quickly as we can to get them participating, or request that you use a participating provider. Therapeutic days will be reimbursed at 100% of the then current per diem rate, and will be covered up to 30 days per calendar year. So basically all of those guidelines is what you were doing prior to 1/1 of 18. Exceptional DME. I know there's some confusion around exceptional DME. The ultimate goal for UPMC Community Health Choices will be to have the exceptional DME network built and participating so that those claims come directly from the participating network. When I look at your DME items and we talk about wheelchairs, for example, we have a full wheelchair power mobility network within UPMC Health Plan that should be used to provide those items. They have been educated on how they are to get approval for the items, etc. So those should be going directly through the power mobilities. Beds we are working on. We believe that some of you are working with a bed company that is not participating with us. So we will process the DME, that bed, directly to you based on what you were doing prior to 1/1. We'll talk about transportation in detail at the end of the presentation. Mobile X-ray, we are in the process of contracting with all of the mobile X-ray companies so that you can use them. They will be contracted for X-rays only. If you are asking them to do anything outside of that, they are going to request that you request authorization, just like you do on the Medicare side. We'll talk about service coordinators in a minute, but you do have a service coordinator. For each facility has a service coordinator assigned to them. That service coordinator can assist the facility in determining providers and appropriate exceptional DME. The exceptional DME will follow the then current DHS guidelines as for covered items and limitations. Exceptional DME should be provided, again, by a UPMC CHC participating provider when available. Our web directory is available online for everybody to look at. If any education is needed on that, you can contact us and we can help you with that. If the DME provider is not PAR, then you can submit the claim as you did prior. We're working to ensure our system is prepared to accept those claims. Other medical expenses, we are prepared to see those on the claim. We understand how you're putting them on the claim and the things that are being put on the claim. Again, some of the differences that I see in the other medical expenses is the service coordinator can assist the facility in determining and obtaining the appropriate necessary OMEs. We are asking nursing facilities to really start to begin to do that coordination of benefits. If that member has a Medicare primary, we are asking that you verify that whatever OME you are providing, whether it is available from our participating providers or not, so that we would prefer them to always come through our participating providers. I'll use dental as one. We are aggressively working to increase our dental network so that those dental providers in the nursing facility can submit the claim directly to UPMC CHC, and it does not have to come through the nursing facility. That is a work in progress, but we're continually working to build that network. If the OME is not PAR, then obviously you can submit it on your claim for payment. We do know how to process it, and as DHS did, we potentially could ask you what that OME was based on cost, etc. I know a lot of facilities have some questions about the short-term nursing facility stay. So what I'm talking about is the member who is a UPMC CHC community member and needs to come into the nursing facility for a short-term stay. So this is not somebody who has been determined long-term care custodial. This is somebody who is definitely looking at a short-term stay, maybe after a hospitalization for rehab or whatever it is they might need. If that member has Medicare primary, Medicare remains primary, they would go into the facility on a short-term skilled stay, just like they always have. It does require authorization under their medical benefit, the same as any other authorization. So nothing changes there just because they have CHC, as long as they have Medicare primary. If there is no Medicare primary, as DHS says, there is no skilled benefit for community health choices. Members will be accepted into the nursing facility under the UPMCHC nursing facility benefit, and there is no authorization required. Financial paperwork, per my discussion with DHS, is to be completed on these members the way you always have done that. What DHS is asking is that you ensure when you're filling out that paperwork that if that member already has a UPMC Community Health Choices plan, that you are indicating that so that member is not inadvertently auto-enrolled based on the application that you're submitting. If that happens and they get auto-enrolled into another CHC plan, you want to call the IEB immediately, and you can contact us. The nursing facility per diem rates will apply, and the billing will be the same for these members. If the member is deemed that they will not be leaving the facility, then you would go through your standard process to ensure that they become long-term care members. Okay, a little bit about the service coordination. So DHS has required that as a new feature of Community Health Choices effective 1/1/18, that all nursing facilities have an MCO service coordinator that is within the facility to assist the individuals residing within the nursing facility. This is new, and we are aware that it is new for the nursing facilities. We ask your cooperation. It's new for everybody. They are new. You guys are new. So we do ask that we work together to ensure that we're giving the member the best service and care that they need and with the resources that we are offering for them. Right now, DHS has directed that we will be using the MDS assessments within the nursing facility, and we do ask that the service coordinators have access to the MDS data. I think each facility is going to be a little different on how that occurs, and I think that has to be a collaboration between the nursing facility and the service coordinator that has been assigned to your facility. Members do have choice of service coordinators. I know that that has been asked in the past. There is a service coordinator assigned to each facility. If for some reason that member would like a different service coordinator, they would be working through our member services team to request a different service coordinator, and then we can work through that portion. Nursing home transition will still occur as it did prior. The difference is you will have the service coordinator involved, and our service coordinator in the nursing facility will be a liaison with the service coordinator that is in the community to ensure that that transition is smooth. The goal of this new Community Health Choices is to have this person-centered planning team. Each member makes the decision of who they want on their person-centered planning team. But it could include the participant, family member, nursing facility, discharge team, UPM CHC service coordinator, physical health providers, external nursing home transition provider if that's who's being used. So we are very adamant about following that person-centered planning team. We've had nursing facilities ask us about how involved the service coordinator should be in any of these members whenever you're having member meetings with the family, etc. That will be individual between the facility and the service coordinator. However, the general consensus seems to be that the service coordinator would like to know anytime that the member is having any type of meeting or anything so that they can participate if necessary. Critical incidents, this has changed a little bit since our original presentation that we did to you guys back in November. So it changed significantly in the sense that DHS is saying that nursing facilities are not required to submit critical incidences to UPMC Community Health Choices. Initially, it was said that they were. They now are saying that they are not, and that you're to be following your normal processes for reporting. So everything that you did prior to 1/1 and with the state and every other entity that you need to report to. The one thing that is different is the PSAE reporting. We ask that you refer to the bulletin and follow the steps that you've always completed, so nothing is changing in that. You're following your normal process. The only thing we're asking is that nursing facilities send a secure email to us at the email on this slide and with a copy of the PSAE event report so that we have it on file and we can review to determine if we need to be involved or need to have our service coordinator involved at all. If there's questions about that, you can definitely ask the questions. We will try to get another more in-depth information session out to you guys on this, but at this time, all we're asking for is that you do provide a copy of the PSAE event report so that we have it. If you cannot send a secure email, you can email that email box and they will reply back to you with a secure email so that you can then reply within the secure email. Provider disputes, these have not changed at this time because they are basically the same process that you had before. These are not skilled stays, so they are more administrative than they are medical necessity because we're not requiring any authorization or anything for the member to be in the facility. So any provider disputes that you have would more than likely be administrative based on payment, et cetera, that you might have questions on. Provider disputes do not include appeals filed by the provider on behalf of the member with the member's consent. It does not include the resubmission of a corrected claim due to a minor error or an omission would not be an appeal. Those are corrected claims and would be submitted accordingly to request a corrected payment. Administrative disputes must be requested within 30 business days of the date of the EOP. That is very important. They will decline the appeal if you do not have it in within 30 days. So I want you to make sure that if you are questioning something, you file the appeal. Decisions on appeals will be made within 60 business days of the receipt. All administrative appeal decisions are final. If the appeal is upheld, the provider receives written notification of the reason. The provider is notified that the decision is final, and notification is sent within 10 business days of the decision. If the appeal is overturned, the claim is re-adjudicated within 30 business days, and the provider is notified by way of an EOP that the claim has been updated. Member disputes. Members very much still have the right to file member disputes. We will be following the DHS guidelines for Medicaid member disputes. They may file their complaint by phone or in writing. The provider may file a complaint on behalf of the member, which is something that you're basically doing already, as long as you have written permission from the member to file the appeal in their name. The member dispute is clearly outlined in our provider manual under the CHC section. So I suggest that you, if you have questions on that or that comes up, you go out and look at that. You also have access to our provider manual, and I suggest that you involve the service coordinator also before you start filing an appeal to the member to make sure if there's anything that they can assist with. My next topic is transportation, and I don't think that Ed has jumped on. So Wendy, would we be able to move on with some questions on what has occurred thus far until Ed jumps on the phone?
You got it. Can you see the questions? I'm adding you as the answerer. Can you see them?
Hang on, I think I can. You know what? Can you read them to me, Wendy? I can't see them clearly.
Sure, you got it. All right, we'll start at the top. How is it handled for a participant liability is split between a FFS claim and a CHC claim due to the approval was received? Not sure if that makes sense. Example, patient liability is $1,800 per month, I suppose, and FSS pays, looks like 1/1 through 1/5/18, and they will take $1,000 for liability and pay $0. CHC plan claim is 1/6 to 1/31/18. Only liability should be taken is $800. How is that reported to you on claim so you do not take the entire $1,800 on the CHC claim?
I think that I'm going to ask that question be sent to us directly, to Danielle or myself, so that we can respond accordingly. And if we need to, we can send the answer out to everybody.
Okay.
I want to make sure I have a complete understanding of that.
You bet. And maybe we should do a one page, or maybe more than one page, but a sort of a frequently asked question, which we can follow up and send out later on some of these, because I will have the questions in a report, at the end of the webinar that I can send over to you, Andrea.
Yes, okay. I think that's a very good idea. That one's a little detailed, so I'd like to look into it further.
You got it. Okay, so the next one is, since UPMC is not currently contracted with mobile X-ray, can we bill UPMC for the X-rays for their members until the network is built?
Yes, you can. And
Okay.
we do anticipate having that network finalized within the next couple weeks.
All right, awesome. The next question is back to hospital bed holds. Do we need authorization for bed hold days or just let the care coordinator know?
Just let the care coordinator know.
Okay. The next question is, who do we send the hospice provider we use to?
Send that to Danielle, or you can send it to myself or Danielle, but if you send it to Danielle, we'll outreach to see if we can get a contract with them quickly, if they're not already par.
Okay. I believe Ed is on the line now. Do we want to go to Ed or do we want to continue with questions?
Unless you disagree, maybe we continue with a handful of the questions, because I think transportation is going to bring up its own set of questions. So maybe we handle it separately.
Surely, I'm good with that. Okay, for the next question, if Medicare is primary for short-term skilled, what requirements are required to have co-insurance paid beginning on day 21 for a CHC member?
Well, I'll answer that separate off of this one.
Okay. All right. The next
I need to verify that one with CHS.
Okay. The next question is, are we required to obtain approval from service coordinator for services that are billed as OMEs?
You're not required to get approval from the service coordinator, so the service coordinator will not be approving it, but the service coordinator should know the situation. So if the member needs a very expensive hearing aid or dentures or whatever it is you might be providing, the service coordinator should be made aware of that, so that there is a discussion made between everyone to make sure that the item is truly needed and that the appropriate provider source is being used. But it is not really an authorization.
Okay. Next question, is the change to the reporting of the critical incidents recent? In other webinars with the other plans, we have been told that we must submit critical incident reports to them.
The answer to that is yes, it is recent, and I'm not sure when the other presentations were done, but this is very recent. It changed for all provider types, not just nursing facilities. So yes, it is new. And I will request that our critical incident team prepare documentation to send out to you guys to better clarify it than maybe I did just now.
Okay. And just to clear things up for everyone on the line, the slides will be sent later today. We will provide that a copy to, a link to the handouts, to the PowerPoint presentations later today. So that to clear that up for everyone, that has been a question that has come up, and yes, we will. And like I said, on a lot of these questions, we can take them and send something out. Take a couple of days and try to get those in a hard copy form and send them out to everyone. Okay, next question. With the updated direct portal entry now, could we do adjusted claims versus paper adjusts?
Yes, you can submit a corrected claim on the portal. You just have to make sure it's indicated as a corrected claim. You can, but to clarify, and I'm assuming this is probably known, but you have to submit an entire new claim as a corrected claim. So you cannot go on the portal and pull up the old claim and quote fix it. You have to submit a brand new claim. But yes, you will be able to submit your corrected claims that way.
Okay, great. Next question. Someone comes into our facility covered under UPMC for life for skilled care. They also have UPMC CHC. Are you saying that once their need for skilled care ends, they can remain in our facility and you don't require authorization? If so, for how long before we have to apply for Medicaid coverage for long-term care?
If they are staying past their Medicare skilled stay and going into CHC, you should start the paperwork immediately when they go under CHC. So you want to immediately start the paperwork for them for their financial responsibility within the nursing facility. There are guidelines and rules as to how payment is going to be made to this member type, and we will get further information and details out to you on these varying different payment methodologies. In that one, the Community Health Choices will be required to cover them back to when they become eligible.
Okay, ready
So
for the next?
Yes, go ahead. Actually, go ahead.
Okay, for short-term skilled nursing facility stay, if they have no skilled benefit, how do we accept them into skilled, and how do we bill for this?
There is no skilled benefit. There is no skilled payment if they are straight CHC. The only way they go back into a skilled stay is if they have Medicare. The easiest way to say it is there is no skilled benefit under Community Health Choices. Even if they're at a skilled level, they come back in, or they go into the facility as a CHC member. The only way they get a skilled benefit is if they have a primary insurance that has a skilled benefit. So they're coming in they would come in just under your straight CHC per diem. So there is no skilled and there is no authorization for skilled.
Okay, next question. Will the portal update allow for keying in claims or only batch updates? Also, will this be for all UPMC plans or only for the LTSS claims?
The portal is already available for any other claim to be keyed in, so you can key a claim into our portal at any point in time for a skilled stay, etc. What we had to do is update the provider portal claims entry to allow it to accept the LTSS, the codes, the condition codes, etc. on the LTSS claim. So that was the update that had to be made. So the answer to that is you can submit all of your claims via the portal if that's what you're looking to do. But we recently updated it to accept all of the fields required for the LTSS claim.
Okay, next question. Can you clarify when a patient should admit with an authorization form the plan or from the plan, and when they would not?
The only time that they will have an authorized skilled stay is if they have Medicare primary and they're using that benefit. There is no skilled benefit in Medicaid CHC, which means that if they are a straight CHC and they do not have any primary insurance, and CHC is their primary insurance, there is no skilled. They come into the facility under the per diem rate for their short-term stay. You still complete the paperwork like you always do, and then they are discharged upon appropriate discharge. And the service coordinator will also be there to assist if there's any transition to home that needs to occur even after a short-term stay.
Okay, next question. Do we have to notify you using the PSAE form for critical incidents?
Not for anytime that you are completing a PSAE form as you're instructed to do prior to 1/1, that is the form we need copied. If it's a standard critical incident and you are not required to complete that form, we do not need to know about it. You need to just follow your other processes that you've always done.
Okay, next question. Currently, skilled nursing facilities do not have the ability to submit a PDA waiver/respite claim on the web portal on a profession claim form. How do we submit a respite claim?
I will follow up with everybody on that question. We were attempting to have that done via just using your per diem Rev 100 code, but I think that's causing some confusion. So we are going to define an exact process for that. If you have somebody right now that you need that for, please contact Danielle and we'll talk through it.
Okay, this one may have already been covered. If paper claims are submitted, how long does it take to get paid for those claims?
When you submit a paper claim, it is a little different than an electronic claim because the paper claim has to go to a PO box, and then the mail gets brought to us, and it has to be scanned into the system, and then it is processed per standard process. So it can add a little bit of time to the processing just based on those steps that it has to take, but it should not be an extended time that would be beyond any payment terms that we have.
Okay, next question. Will the bad debt cross over, or do we still need to file a bad debt report?
You still want to file a bad debt report because that's a Medicare report. I believe I answered that correctly. If I did not, somebody can send us an email and we'll get clarification. But to my understanding, that's a Medicare report, so that can be sent via the Medicare.
Okay. Here's another one. This one may have already been covered. If we have been sending any critical incidents to the service coordinator, is that okay to do?
Yes, that's fine.
Okay. Next question. Will there be a live person to assist with DME billing?
Not trying to understand how to answer that. I'm Wendy, unless you can decipher that, I'm not quite sure how to answer that.
Maybe if the person who asked that question could just clarify in another question. Again, it was, will there be a live person to assist with DME billing? Again, if that person can clarify in the question pane, that would be helpful. Next question. It's a claim question. What is required on an adjustment claim for change in patient liability?
You want to submit the exact same claim using the bill type as a corrected claim, and then you want to put the adjusted member liability on that claim. Our system will read the claim, see the differences, and process accordingly. What you need to be aware of is when you submit a corrected claim, what you're going to see is the original claim will be denied in its entirety, and the new claim will be processed for the correct payment.
Okay, and just to, again, I just want to let everyone know who's on the line, the people are, sort of coming and going from, I can see from our statistics over here on the side that people are coming and going. Just to be clear, we will take these questions, send them to Andrea, and we will try to get a document with our staff, with Gail Weidman and also Andrea. Between the two of them, we will put together a document that we will send out within a couple days. Give us time to get that prepared, but the PowerPoint will be sent later today along with the recording of this webinar, and we will have those questions that I will be able to take and send to the presenters and to our staff here at PHCA. All right, the next question is,
you know what, Wendy? Wendy, on that note, I think we should move on to transportation because I want to make sure that we leave enough time for transportation.
Sounds great. We do still have several questions, so I think that sounds great.
If we have time afterwards, I'll gladly pick up some of those extra questions. Otherwise, we will attempt to answer them, as you said, in writing to everyone. But I don't want to cut short transportation because this is a very new process for everyone. So.
Okay. Ed, are you on the line?
I am.
Do you have slides that you want to have shown?
No, I think I can just by talking.
Yeah.
Okay, sounds great.
So, Andrea, did you already cover the transportation slides, or are we doing that now?
We're doing that now. So, Ed, if you would just introduce yourself and Coordinated Transportation Solutions, then I will go through the slides and you can intercede if you have things that you'd like to add.
Great. Okay. Well, thank you, Andrea. My name is Ed Platt. I'm the Vice President of Operations here at Coordinated Transportation Solutions, or CTS. We are a nonprofit 501c3 transportation management firm. We basically service the eastern part of the United States with a focus on the Northeast and the Mid-Atlantic states. We're celebrating 20 years of business this year, and at a high level, we manage about 2 million trips per year for various organizations that are health plans, nursing facilities. We do student school transportation, workers' comp transportation, state organizations like DHS, and essentially our mission is to increase the availability of cost-effective and efficient transportation services to transportation disadvantaged individuals and communities. With that said, Andrea, I guess if you want, you can sort of go through the slides, and then I would also like a little bit of time, if I can, to sort of outline, what they can expect when they call in for transportation needs, and what are some of the elements that we're going to be looking for from them to coordinate a really good experience for transportation needs.
Okay, I think that's a good flow. So, as Ed said, CTS is the call center that UPMC Community Health Choices is using for all of our member transportation. On the slide that you guys are looking at right now is the telephone number that you will use to contact Coordinated Transportation Solutions. That number is 844-335-5921. The nursing facilities per DHS guidelines will be doing all of the coordination for the members in their facility based on the transportation needs that these members have. CTS will coordinate all non-emergent transportation, and they will also be coordinating non-medical transportation that is occurring within the skilled nursing facility. They have as Ed said, there's a full contracted network of providers. You coordinate the transportation with CTS, and CTS handles everything from there. They will do the coordination. They will inform you of who the transportation provider is and confirm all of that. CTS then bills UPMC Community Health Choices directly, and we process the payments through CTS. So the nursing facility will no longer be billing for those services. That will occur between CTS and UPMC Health Plan for that payment process. A few things that I want to talk about. We're going to attempt to get a grid out to you guys that helps explain this a little better. But we talked about coordination of benefits earlier on in here. And one of the things that I'm not sure was occurring in facilities prior to 1/1 was the actual coordination of this transportation benefit. So if a member has a Medicare SNP dual eligible plan, that plan probably offers some version of a transportation service. Now, will other dual eligible plans allow that to be used in a nursing facility? I don't know that. We would ask you to coordinate that benefit, though. If they have Gateway's dual eligible plan, verify with them if the transportation can occur under their Medicare plan, which is where we would prefer to have that transportation occur. For our UPMC for Life dual Medicare plan, we do have a value-added benefit. Those members for 2018 get 50 one-way trips, which are non-emergent medical trips. So these are not non-medical. These are non-emergent medical trips. They can go to the physician's office, specialist office, diagnostic imaging, lab, dentist, behavioral health, etc. The service coordinator and provider services can help assist with the benefit structures of this, or you can contact us, and we're going to try to get you guys some information out so you have a full understanding of the level of these benefits. The call center will coordinate transportation, whether it is the SNP dual eligible or whether it is Community Health Choices. Okay, so you only have to make one call. If that member is fully integrated with UPMC on both dual and CHC, it's one call. You're calling CTS. CTS, when you make that call, and Ed will talk about this a little more in a minute, but they're going to be asking you, does the member have a UPMC Medicare benefit, so that they know which one it's going under. For the nursing facility, it really doesn't make a difference. It's all the same coordination. It's all the same transportation providers. The only difference is the payment structure and who is actually internally at UPMC being billed for the trip. The SNP non-emergent transportation benefit covers wheelchair van and ambulatory transportation, medical, taxi, lift, etc. Why that is key is it does not cover an ambulance, which means an ambulance would then shift over to their Community Health Choices transportation benefit. So when we are looking at the transportation benefit, there are two different types of transportation. There is non-emergent transportation and there is non-medical transportation. Non-emergent transportation, they are either Medicaid, if Medicaid is either primary or secondary. Again, you want to look at their dual eligible plan to make sure that all of their Medicare benefits have expired. If they are not available, the trip then becomes Community Health Choices. If they are Medicaid services only, it all comes under their non-medical transportation, and the call center will coordinate and bill UPMC directly for the services. Again, the service coordinator can assist. I will point out that per DHS guidelines, MATP is not used within the nursing facility, so that is not one of the transportation modes that we will use. When we were looking at the non-emergent transportation, we will be looking at using for Community Health Choices, we will be looking at using wheelchair vans. We will be looking at ambulance, stretcher vans when available, we are attempting to not use any of the paratransit, any of the lifts or cabs or anything in a nursing facility unless specifically requested, because that doesn't seem to be working well, and it looks as though you guys really need door through door, so that's what we're trying to get for you. For non-medical transportation, that is any transportation that is not medically related. It could be that that member is going to, well, God forbid, it could be a funeral, it could be a wedding, it could be wherever that member is going to outside of the facility that is deemed to be part of their plan of care. These transportations need to be on the plan of care. We are not authorizing them. We are using the nursing home discretion as to when the transportation is needed. However, it does need to be on their plan of care. There needs to be a reason for them to be going to do what it is that they are doing. And again, CTS will coordinate and bill UPMC directly for any non-medical transportation. If you are a nursing facility that has your own vehicles and are providing your own transportation, you cannot, I know there's a lot of questions around this, you cannot bill UPMC directly for that transportation because you do not have a provider ID as a transportation provider. What we have asked that you guys do is contact us with an outline of your transportation provided by the nursing facility, so we understand that most of you have done that. What we're asking you guys to do is use the transportation worksheet, which everybody used in January, to bill me, not CTS. If it goes to CTS, they'd get it to us, but we want that to come directly to us because we will reimburse you directly for that transportation that you're providing. We are going to use those worksheets to determine the type of transportation you're providing, where that member is going, the volume, and the average cost. We are making a decision internally whether we are going to have facilities work directly with CTS for their own transportation, which would require an agreement with CTS and have those coordinated through that process, or whether we will look at a type of a per diem increase. So for now, we are asking you guys to use that transportation worksheet to bill us for any of those services while we get to know that. We will have additional discussions about this as we move on. I'm going to do a page up there. Okay, so Ed, do you want to pick up at that point with some of the information that you wanted to provide to them?
Yes, thank you. Really, I thought it would be helpful to go over the elements that we're going to be looking for, so you are prepared for the questions we're going to ask when you call in for a transportation need. And it really starts with getting the member information, so a member's name, a date of birth, an ID number, and a home address. That way we can pull up the member in our system, and we get a file from UPMC daily. So we'll know if they have just SNP, if they have CHC, or they're fully integrated, and where the benefit should apply to, so we can help with that as well. The second question really that we will be asking is if this is a reoccurring need or maybe a one-off trip request. If it's reoccurring, or what we call a subscription, we really would prefer to book that one time with you for a period of time, let's just say 6 months. If it's a consistent every Monday or every Monday, Wednesday, Friday, etc., as long as it's consistent, we can do that one time, and you don't have to keep calling that in. Obviously, we need to get pickup and drop-off information, dates, times, actual addresses, the name of the facilities they're going to, and any comments that are very specific about the pickup or drop-off is very helpful for us. We'll then be asking about mobility needs. Does the member have a walker, a cane, a wheelchair, an extra large wheelchair, motorized wheelchair? All that information is very key to making sure that we have the right vehicle being sent out to pick up the member. We'll ask what type of trip or what's the reason for the trip. Is it medical? Is it social? If it's medical, is it dialysis? Is it, just a regular primary care physician visit, etc.? We want to document the reason for the trip. We'll also ask if it's helpful to get a reminder call, and we do that through an automated IVR system. It's up to you and the member to get that or not, and obviously we'll need to know a phone number where to make that call out to. And with that said, we also ask for a number where we can reach someone in case there is an issue, if someone's running late or weather-related issues. We want to be able to contact either the member or someone who oversees their care, so we can make alternative arrangements if necessary, or we're having trouble finding someone, etc. That is very key. And then getting into the actual transportation provider assignment, as Andrea alluded to, if you're providing your own transportation, we just went over that and how to handle that for now. And then if you're not doing your own transportation, then we'd like to know which provider you're currently using. Our hope is that we have them already under contract and we can use that and it would be seamless. If they are not, we want to get them under contract, and we will encourage you to use one of our participating providers that we already credentialed and contracted, so we could, again, make sure that we are getting someone who's fully vetted and providing transportation needs for you. I think that really covers everything that I thought was pertinent to you guys. I don't know, Andrea, maybe we can open it up for some questions.
I think that's a good idea. The one thing I want to stress is that the relationship between CTS and UPMC Health Plan, Community Health Choices, is looked at as a partnership. So we are asking that we all work together. It's new for everyone. So we will work out anything or any questions that you have. We'll definitely work out. I want to stress that the need for the details when you contact CTS is vital. If you have all those in front of you and ready to go, then that process will be much quicker and much easier to process. Also, just that having a nursing facility contact, a direct contact that CTS can call person, will also make this a much better success than if CTS has to call a general number at the nursing facility and try to find somebody who can help them. So go ahead, Wendy. I think you can open it up to questions if you'd like now.
Okay, great. There are several questions around where to send the transportation log to.
You can send that out to Danielle. All of your key administrative staff should have details on that. If not, Danielle's on the call. We can get that sent back out to everybody if we need to. We've been receiving a lot of transportation worksheets, but we can send another email out to everyone to ensure that they're being returned and getting to you.
Okay. How does the next question is, how does the dual eligible with ESRD benefit work with the 50 one-way trips? Is there a carve-out for ESRD?
There is, and one of the things that we are going to get out to you guys is we're trying to make it as simple as we can, is a kind of a benefit grid so that you can see the progression of benefits. Dialysis trips are a medically covered benefit. Medicare covers those trips. CTS is not functioning at this time in this area as our medical transportation coordinator. Most of you are used to calling NORCOM. NORCOM is still the one coordinating the non-medical covered benefits, such as dialysis, facility to facility, so hospital to facility, etc. So we will get a grid out to better explain that to you, but dialysis is a covered benefit. It doesn't need to come under the SNP, and it doesn't need to come under the CHC because it is LTSS, I should say, not CHC. It is a covered benefit, transportation.
Okay. The next question, is there any special consideration for residents who go out for dialysis? They will use their trips very quickly.
That goes right back to what I said. Dialysis should be coming under their physical health benefit, which means the EMS company, I didn't phrase this prior, I will phrase it again. The EMS company should be billing us directly for those dialysis trips. And if it's something that you are currently paying for on your own, those should be, the EMS company should know that that's a covered benefit and they should be being sent to us directly. And again, I'll try to get some clarification out to everyone on that so you can see the levels and how you should be handling those trips. But those dialysis trips should not be coming out of their SNP benefit or technically their CHC benefit. They should be coming under their physical health transportation.
Okay. Next question. We are a nursing facility that provide our own transports. We were told to contract with CTS, which we have already. Are we to disregard calling CTS and just use the spreadsheet?
Oh, Ed, let me provide one clarification and then you can answer that. I think the person who submitted that has a true transportation. There's a difference between a facility that has their own van, their own wheelchair van, that is taking members here and there, and an agency that actually has a true transportation that is PUC licensed, etc. I'm assuming that's who that question came from because that's the only provider that would be contracted to CTS. If you are contracted through CTS, all of your transports should be going through CTS.
Okay.
And sorry.
I'm sorry, go ahead.
I was going to say, since we're still trying to figure out which way we're going to go, whether we're going to have providers who do their own transportation, either directly contract with us or an increase in their per diem, I did ask our field supervisor to start to outreach to all of you nursing homes to get a better understanding of who does their own transportation, who does not. So that could be sort of, we're just trying to get a head start on knowing that, and then, what is the number of nursing facilities that do provide their own transportation. So that could be causing a little bit of confusion. I'm going to ask Jim to continue to do that outreach to you guys, but we're going to wait on, further contracting until CTS and UPMC make that decision.
Right, I agree. And I do think that the person, I'm guessing, that sent that in is that we know of one nursing facility that has a true transportation division that is PUC licensed, et cetera. That provider we would want definitely to contract with CTS, but for the facilities that just have their own van that they're really only using for their own residents, those are the ones that we want to continue to use the worksheet. I think we are probably going to lean towards using CTS as a contracting agent, but we want to get an idea of what you're doing. So CTS's calls to you guys, as well as the worksheets that we're getting, will help us gather that information.
Okay, great. The next question, and again, some of this I'm sure has been covered in other, in some of the answers that you've already put out there. So let me just read this one. Is there a limit of trips under the CHC plan like the DSNP plan?
No, there is not. CHC transportation is unlimited. And what will occur is if the member uses all of their DSNP trips, those 50 trips, they'll automatically just move to the Community Health Choices benefit. So in a lot of ways that it's relatively seamless for the nursing facility which benefit they're using. It's really more internally for us and CTS so that they know which division they're billing. Are they billing Medicare or are they billing Medicaid? So it should be seamless for you. Once they use those DSNP trips, they would then just move into their CHC benefit. There is no limit. Although we will be, I will preface that anytime I say the word no limit, we will be getting reports from CTS so that we understand and know transports that are going on. So, I mean, our assumption is that a nursing facility is never going to transport a member for no reason. So our assumption is that if we look in the plans of care, that we will see that transport as a true reason for a transport. Okay. And let me just state also, just to add this, because I'm worried that you guys are having a lot of concern and confusion over the DSNP transportation over the CHC transportation. We want that to occur. We know that it's new. If a trip gets scheduled under the CHC plan and they did have a Medicare benefit, it's not. We realize, especially in the beginning, that potentially could occur. Our goal is to get you guys just used to that level of care and which benefit category, and always having Medicaid as a payer of last resort. So don't think that somebody's going to come in and do anything if a trip goes under CHC as opposed to their DSNP.
Okay. Next question. Will CTS send the list out? There are a lot of requirements.
I can put something together and add it to maybe what you're sending, Wendy, or whoever's sending the presentation out. That won't take me long to do that. And yeah, that's probably that's helpful. Good idea.
Okay. Yep. Ed and I will work together and make sure that we get something out to everyone.
Terrific. Next question is, how do we know the contracted transportation providers?
Go. Go ahead, Andrea. I'm sorry.
Yeah, I think my answer on that would be that you need to call CTS. You have the ability to say, I prefer to use ABC company, whatever that company might be. And if they are not par, what CTS is going to do is they're going to make every attempt to use the provider that you want. Either they'll try via Outlook. They have varying different ways that they can do it, and then they will attempt to contract with that provider. So your knowing of that network will come from the call that you make to CTS. So if you're used to using mutual aid, you're going to call and say, I use mutual aid, and that's who I'd like to continue using, and then you'll work through that with CTS. We can't guarantee we can always use the facility that you want to use. because they could not be available. They could be things along that line, but the goal is to make an attempt to keep it seamless for you.
All right.
I will tell you there's a robust network of providers right now.
Great. Okay, the next two questions go together, so just bear with me. Can you send out a list of all questions that will be asked when calling in to schedule a trip? And then it says, again, the next separate question is, can you create transportation forms so we have it all filled out with the pertinent information needed when we call?
The answer to that is yes and yes. Interestingly, Ed and I, when we were talking about this call yesterday, we're talking about maybe creating a form so that you guys would exactly do that. You would have it in front of you, completely filled out, so when you call, you have all the information. Plus, it's something that you can keep in that member's file. So yes, we will work on creating something like that for you.
Great. Sounds like a great idea. The next question, is a transportation application to be filled out once they are approved for the plan?
Not sure I understand that. That may be coming from, it's my understanding from that I've hearsay is that the other MCOs are requesting that the nursing facilities, I don't know the term, register with their transportation provider. At this time, we are not doing that. CTS is not doing that. If we deem that necessary, we would let you know. I'm guessing that's what that question meant. So the answer to that is no, you don't. You just need to call CTS. And CTS, I should point out, does have an eligibility file, so they are able to confirm that the member is our member, etc. That was not mentioned.
Okay. Next question. What if they are Security Blue Primary and CHC UPMC? Who do we call for transportation if they are skilled?
Skilled will continue to follow Medicare guidelines, so don't get that confused. They're still under Medicare. So if they're under, I think you said Highmark, if they're under Highmark Primary, then Highmark Primary is who should be doing their transports. They're under a Medicare benefit at that point. They're not under the CHC benefit. So you're skilled, you can't cross the skilled benefit over to the CHC benefit when it comes to transportation.
Okay. Next question. Our ambulance provider is contracted with UPMC, but we are still receiving bills from it for non-emergent transportation, and the ambulance provider is telling us to pay it while they straighten things out with the MCOs. What should we do in this situation?
You need to continue to pay the non-emergent transportation provider if you did the coordination. If you coordinated that trip directly with them, which is what happened in January, everybody kept coordinating their own trips, yes, you do need to pay them. If you are coordinating that trip through CTS and using the call center, and we're hoping that everyone is going to be able to switch to that starting here on March 1st. If not, we can talk through that, but if it is coordinated through CTS, you should not be paying the ambulance company separately, or the EMS or any transportation that's coordinated through CTS. That payment will come directly from CTS to that provider. And if you have specific issues, you can let us know.
All right. The questions are continuing to come in, so we'll take them until we'll give about 11 more minutes. And know that if your question isn't answered on the line here, that we will be sending those to Andrea and Ed and also Gail Weidman, and we will work together to get the answers and send out a document with all of the questions that have been asked on today's webinar so that everyone will have the document in front of them with the answers. The next question is, how can someone be added to the UPMC email distribution list?
You can email Danielle, and her email address is on the presentation that that'll be posted. So you'll be able to get it from there. You can email Danielle, and then we are tending to work with the administrative staff, with the administrative corporate staff with nursing facilities. So we would definitely run it past them that you're requesting, and we don't have any problem sending it to everyone that we have on the list.
Okay. Next question. Does the patient need to meet medical criteria for going by ambulance versus W/C, or wheelchair, I guess that is, for the transportation to be covered? If the benefit limit is reached for transportation, is the patient billed for transportation costs after that?
So I'll handle that in a couple levels. Again, Ed and I talked yesterday about that medical necessity. It is very normal for a transportation provider to review for medical necessity to determine that the member is meeting medical necessity. We have not made a final decision on that. And one of the reasons that we haven't is there will be times when a member potentially is eligible for a stretcher van that is not eligible for an ambulance. However, we may not be able to locate a stretcher van provider, and we might have to use an ambulance provider. And that will be at the discretion of CTS to make that decision. And so we will outreach to everybody about the medical necessity once we make a final decision. What I will say is we do ask that the nursing facilities use their discretion in making the determination of the least costly transportation that member can go on. So if that member can use a wheelchair van, we would request that they go in a wheelchair van. If there truly is a reason that they can't go in a wheelchair van and they qualify for a stretcher and we can't locate we don't have a stretcher provider, that's our decision to handle it that way. But we would ask that you do not request an ambulance for a member that does not qualify for either a stretcher or an ambulance, unless there is a real need for that.
Okay, that was the next question is, if a resident requires stretcher transportation, will it be paid for?
Yes, DHS has written that into our agreement. We do have to pay for this stretcher transportation. But as I said, if as we build the network, stretcher vans are becoming harder and harder to come by, so we may end up having to use an ambulance, and we are aware of that. I didn't answer the other question. The person asked whether the member would be billed for their transport. A community health choices member should technically probably never be billed for a transportation, because it should always be in their plan of care and as a covered benefit, unless somebody wants to provide a specific instance where you think that would happen. So the CHC benefit is unlimited. There's not a cap to that.
Okay. The next question we have is, what is a one-way trip? Is each direction for a to-from appointment considered one-way trip?
A one-way trip would be from the facility to the doctor's office. That's one. And then from the doctor's office back to the facility would be two. The only reason we list it as one ways is in the event the member, for some reason, is literally only going one leg. It's happened before where a child or somebody picks them up and brings them back. So that's why we do one way. So one way is from the nursing facility to the doctor's office.
Okay. Going back to dialysis transport. For the dialysis transport that is covered, there is a copay billed to the resident. Will the copay be covered?
I assume that's referencing Medicare, and we just talked to the EMS providers about that, and that they should be submitting it for secondary payment consideration under the CHC plan, but that should be occurring by the EMS provider, not by the nursing facility.
Okay. We have another question here. To clarify, does NORCOM provide or handle non-medical or non-emergency transportation or medical-related non-emergency transportation?
They handle and the grid will help you understand that they handle medical non-emergent transportation. They do not do any non-medical. And there are only a handful of services that are covered under their Medicare benefit. It is dialysis. It is a trip from facility to facility, so that can be nursing facility to nursing facility, hospital to nursing facility, etc. And it can be, it would be nursing facility to home if that happened to be a trip that was being done. So there's only a handful of those trips that are covered under the medical benefit, and they have to be medically, that one they do have to be medically necessary to use the ambulance or the wheelchair van. So you can't just use that transport, they have to have that reason.
Okay. We have about 4 more minutes and several questions, so we'll get in as many as we can, and then we will send these all over to our presenters and have them answer them and, give us some time so that we can send those. But everyone who's been on the call today will receive that. The next question is, can requests for trips be made at any time? Are there a certain number of days before the transport in which request trips need to be made?
Ed, I'll let you answer that.
Wendy, can you repeat that? I'm not quite sure I totally follow.
Can requests for trips be made at any time is the first part. And then, are there a certain number of days before the transport in which requests for trips need to be made?
Got it. All right. Sorry. So under normal circumstances, we would like to get at least 48 hours notice of a routine request. If something is urgent, obviously, then, really we're looking for up to 2 hours notice. But, if you have the time, please allow that, and it'll have a better success rate in getting the right transportation provider for you assigned when we have more notice.
Okay. Next question is, what happens if we use a non-contracted transportation provider?
That goes back to the discussion that I had. You still should be calling CTS to verify if they are participating or not. If CTS has the ability to coordinate the trip with that provider as not a network provider, they will. If they cannot, then they will reach out to the provider to ensure that they get them contracted. So they may have to make the decision to use a different provider. That's why we're trying to get everyone to send us their providers that they use so we can try to proactively ensure that they are participating.
All right. Ed, here's a question for you. Is CTS contracting with the other 2 CHC MCOs?
I'll take that.
No.
The answer to that is no. The other 2 MCOs are using a different call center.
All right. Here is a question. If we coordinated the transportation and paid the provider prior to March 1st, will you reimburse us from the spreadsheet we send you?
Yes. Continue to send the spreadsheet. We are asking everyone to transition over to CTS, but we did say for the month of November, and if we have to in the month of March, if you have services that were already coordinated, that yes, you can submit them on the worksheet. But we are asking for any new transports that you begin using CTS.
Okay, we'll take another question or 2 here. Next one is, physicians in our area are requiring an escort to be with residents whose family cannot meet. Will you pay for transportation to wait with them?
I'll take the first part of that, and then if Ed has anything to add. So, when you call in, you need to let them know that there will be an attendant with them. And if I'm understanding that question, what I'm going to answer is that UPMC CHC will not pay the attendant to go with them. I think that's the question that was being asked. And if it is, the answer is no. We will not pay the attendant. We will not pay for the attendant themselves. That was not covered under DHS and is not a required cover for the MCOs.
Okay, anything else on that question?
I was just going to reiterate, if we, please let us know if there is someone coming along for the ride. That way we know and we can communicate with the transportation provider, so they have the availability seating to accommodate an additional passenger. And then wait time, I think, was also sort of thrown in there. Really depends on the actual transportation need and what makes the most sense for whether we have the provider wait or have them come back at the desired pickup time.
And just to clarify that, what Ed is talking about the transportation, the transportation provider wait time. There is no coverage for the attendants themselves.
Oh, right.
Okay, last question, and then we will take the questions and I will get them out we'll wrap this up and I'll get them over to our presenters. And like I said, give us a couple of days just to get those done and answered, but we'll get them out as quickly as we can. The last question is, if a doctor wants to see a resident today and there's no advance notice, will there be any problem getting the transport set up?
No. We'll do everything we can to get that transportation set up, even if there's only 2 hours notice. Obviously, if there's no need for that urgent transportation, that would be helpful, but if they need to see someone right away, we will do everything we can to make that happen.
Okay,
I think
terrific.
the key phrase is there that, as with any transport, we'll do what we can to make sure it happens because of the availability of a provider.
Okay, great. I want to thank Andrea and Ed for your time and the great information today. And just a reminder that I will be sending out the slides today, along with a link to the recording. And I'll also be sending a link to a survey. Please take time to fill out that survey. Your feedback is important to us. We use that information to help improve our webinars, and we take that feedback seriously, and we want to make things better for you all. Again, thank you to Ed and Andrea, and we'll wrap things up. Everybody have a great day.
Thank you, everyone.
Thank you.